Well, good afternoon, everyone. A great pleasure for me to present today an update on COVID-19 vaccines, what's available and what's coming in the future. First of all, my disclosures. We currently have, or as of May the 17th, 12 COVID vaccines available globally. Many of them you'll be very familiar with, and all of them will vary in the different countries depending on where you live. But today in my talk, I'm going to mainly focus on the Pfizer and AstraZeneca vaccines, as these are being rolled out in many countries in the Asia Pacific. I will briefly talk about the Novavax vaccine and Janssen vaccine as well. So what do we want from a vaccine? Well, I think it's important to understand the natural history of COVID-19 and where a vaccine can interfere. This is what we know about COVID. About 20% of people will have asymptomatic infection. About 60% will have mild to moderate symptoms, and about 20% will have severe disease. And this distribution, of course, depends upon the age of the person infected. First of all, from a vaccine, the most important thing we want, and the thing that really matters, is eliminating severe disease, eliminating the possibility of hospitalisation or death, because that is what's crippling our healthcare systems currently. Ideally, we would also like to eliminate or just reduce infection, and that's because we all know that long COVID can complicate both mild, moderate and severe disease with a prevalence of about 10 to 15%. Eliminating or reducing infection also reduces the pool of people able to transmit. And finally, ideally, we would like to eliminate transmission. But this last characteristic is quite complicated. It's dependent on how good the vaccine is, whether it induces sterilising immunity, prevents infection, the total number of infected people that are reduced, whether viral load is reduced, and the duration of shedding. And we're only now beginning to understand how effective vaccines are on eliminating transmission in vaccine effectiveness studies or testing vaccines in the real world. You cannot calculate this from the phase 3 clinical trials. So I'm going to speak to you about real world effectiveness and safety data, recent publications on the Pfizer and AstraZeneca vaccines. I'm going to talk quite a bit about the variants of concerns and how it might affect COVID-19 vaccination. And I'm going to briefly mention other approaches to biomedical prevention or the role of antibodies, which I think is a new and important area. So real-world efficacy and safety data for COVID-19 vaccines. This is the total number of vaccines that are currently available in the world, a complicated slide, but a nice summary of the phase 3 efficacy. And you can see the phase 3 efficacy is all within this column for the mRNA vaccines, the live vector vaccines, protein vaccines, and whole inactivated vaccines. And these phase 3 results are, of course, extremely important for the licensing of the vaccine. However, they're all done in different places: the US, UK, Brazil, Pakistan, South Africa. They're all designed slightly differently, so really making comparisons of the vaccine efficacy directly against each other is often not valid. And they actually were done at different times in the pandemic, so the prevalent strain has varied. These earlier studies, particularly with the mRNA vaccine, done with largely the Wuhan strain, and more recent or later vaccines performed in countries where variant strains were much more common. So this is important to appreciate. Phase 3 data allows for licensing of the vaccine. Cross-comparison between clinical trials is a bit more difficult. However, we now have vaccine effectiveness studies assessing what the vaccine can do in the real world. And this study, which comes from Scotland, is a really important study, especially for someone like me living in a country where we're rolling out both Pfizer and the AstraZeneca vaccine. And I know the AstraZeneca vaccine is being widely used across the Asia-Pacific region. So in Scotland, the AstraZeneca vaccine became available first, and prioritised populations were the elderly. And you can see here in pink, most of the elderly received the AstraZeneca vaccine. And in blue is the Pfizer vaccine, where you're seeing more people, younger people, getting the Pfizer vaccine, largely because it was introduced later in the UK response. So in Scotland, they did a prospective cohort study using a national database linking vaccination, primary care, PCR testing, and hospital admission records for 5.5 million people. And they studied between December the 8th and February the 22nd, where it was really largely the Wuhan strain and some of the UK strain. Over a million of this 5 million people were vaccinated, mostly elderly, mean age of 65. And this is fascinating data to me. The effect of the first dose in reduction of hospital admission of 28 to 34 days post-vaccination was basically identical between Pfizer and AstraZeneca, about 88 to 91%. In the UK, the doses were separated a little longer than many other countries. And the combined vaccine efficacy against hospitalisation for people 80 years and older, the group we really worry about, was 83%. So this is very encouraging that in the field, the vaccines work really well against what matters, severe disease. And Pfizer and AstraZeneca look really very similar, at least in an environment where it's predominantly the UK and Wuhan strains. What about protection from asymptomatic infection? Because that really does matter because that's important for impact on transmission. And many countries in Asia have largely or very significantly reduced transmission. And this is a nice study, again, done in the UK, in Cambridge, England, where they looked at the effect of the first dose of the Pfizer vaccine on test positivity rates in healthcare workers, 12 days post-vaccination, and then weekly testing after that. And you can see here in black is at week 1 and grey is at week 2. And you can see the percentage of positive tests less than 12 days post-vaccination and more than 12 days post-vaccination. You can see a very significant decline in the number of percentage of positive tests from 0.8 to 0.2%, showing a 4-fold reduction in asymptomatic infection. So not as good as eliminating severe disease, but a 4-fold reduction in asymptomatic infection. And in the dots here is the viral load. This is shown here as the CT value, which in PCR testing with real-time PCR, a higher CT value means a lower viral load. And you can see here that after 12 days of vaccination, the viral load is significantly lower, or the CT value is higher. So this all augurs well for reducing transmission, a reduction in asymptomatic infection, but not as much as severe disease, and a reduction in viral load. And we actually now have data on the effects of both of these vaccines on transmission. This again comes from the UK, the Household Transmission Evaluation Data Set. It's a passive surveillance system linking laboratory confirmed COVID cases to individuals living in the same household. 5% of household contacts in England were diagnosed as cases. They studied over 500,000 households with between 2 and 10 potential contacts for each case. And the likelihood of household transmission was reduced by 40 to 50%. That's shown here in index cases that were vaccinated 21 days or more prior to testing. So the effect of transmission kicks in at around 21 days and is maintained. It reduces transmission by 40 to 50%, and you can see here equivalent activity of the AstraZeneca and Pfizer vaccines. Finally, vaccine-induced thrombocytopenia. This is something of great concern and really affecting the rollout of vaccines in countries using AstraZeneca. And this is an algorithm for diagnosing it, which has been published by the Thrombosis and Homeostasis Society of Australia and New Zealand, but I'm sure each of your countries has a different algorithm. The principles are the same. The diagnosis includes having thrombosis, or thrombocytopenia and having received the AstraZeneca or Janssen vaccine in the last 28 days. The diagnosis is incredibly important because you cannot give people with this syndrome heparin. It will make the syndrome worse. Therefore, the recommendation is for a rapid evaluation, and if the platelets are less than 150 and D-dimer at least 5 times the upper limit of normal, with or without a low fibrinogen, if it's no to these questions, then vaccine-induced thrombotic thrombocytopenia is unlikely. If yes, and then it moves on to urgent imaging, and we test samples for further evaluation, particularly antibodies to platelet factor 4. If thrombosis is confirmed, it is probable VITT. If there's no thrombosis, then it's possible VITT. And engagement of a hematologist is recommended. Now, of course, we know it's with both live vector vaccines. The pathogenesis of this condition is entirely different to standard blood clots, DVT or PE. This condition is an autoimmune condition triggering activation of platelets through platelet factor 4, and therefore gets worse if you give heparin or platelets. The incidence, at least estimated currently, is about 1 in 100,000. That's what we're seeing in Australia, having given over 2 million doses of the AstraZeneca vaccine, and it can certainly occur at all ages. It's not just in young women. This is slightly old data now, but 18 cases in 1.8 million doses. And with high patient and physician awareness, early diagnosis, and appropriate treatment, we're already seeing that the prognosis dramatically improves. So I personally do not think that this is a barrier to using the AstraZeneca vaccine if appropriate measures are in place to diagnose it early. Can we mix vaccines? We really don't know the answer to that. We're just beginning to see. This is the first study publishing a randomized heterologous prime boost COVID-19 vaccination strategy using 4 different permutations of the AstraZeneca and Pfizer vaccines, and they assessed 28 and 84-day safety and immunogenicity. This is the first cut of the data just published in Lancet, where they looked at symptoms at 7 days after the 28-day interval when mixed dosing was used. And you can actually, disappointingly, when they mixed dosing was used, you can see higher frequency of these non-specific symptoms. We don't yet have the answer for the effect on immunogenicity, and that will still be available. So mixing vaccines at the moment, at least in Australia, is not recommended. Now, quickly, just to review variants of concerns and vaccine efficacy and effectiveness. What is a variant of concern? These are declared by the WHO. It's epidemiological data based on whether the virus is spread more easily, causes more severe disease, or can evade previously acquired immunity better than do circulating versions of the virus. There are now 4 variants of concern. They all have slightly different mutations, but it's the key RBD mutations, or mutations in the tip of the spike, the receptor binding domain, that appear to be most important. You can also assess variants of concern in the laboratory, and looking at how well it binds to the receptor ACE2, if it grows easier in the lab, whether there's resistance to monoclonal antibodies, or whether there's sensitivity to vaccinee sera. And these are the 4 variants that I mentioned earlier. The thing that we pay most attention to and most worried about is sensitivity to vaccinee sera. And the one that we most worry about is the South African variant, which has got reduced sensitivity in vitro. Other features that we can also look at is whether it forms syncytia, more likely to cause disease, the animal tropism, if it affects rodents or not, and if it's pathogenic in animal models. However, none of this really tells you anything about vaccine efficacy until you can evaluate it in the field. And we're now beginning to get those results from large vaccine effectiveness studies. This is one of the first to be reported. It comes from Qatar, and it looks at vaccine efficacy against either the UK strain, B117, or the South African strain. And it looks at the ratio, the effects on infection, or severe critical or fatal disease, with 14 days after. This is just the Pfizer vaccine. And you can see here that if you compare the UK strain, which we know from other studies looks much the same as the Wuhan strain, the effectiveness of the Pfizer vaccine in preventing infection is modestly reduced from 90% to 75%. So the vaccine, the South African variant does have an impact even on the Pfizer vaccine on infection. But if you look at severe and critical or fatal disease, and these numbers are small, the efficacy still remains high. So I think the variants are of concern with vaccination, but from what we're seeing, they're still just as effective on severe disease. We really are getting the best data from studies that are being done actually in South Africa in real time. This is results from the Janssen vaccine, where it was a randomized placebo-controlled phase 3 trial, where done in both the US and South Africa. And the efficacy in the US against severe or critical disease is 85%, so lower than what we know about the Pfizer vaccine in the US. But in South Africa, it was again reduced to 64%. Again, evidence that at least in this vaccine, the South African variant does make a difference. It doesn't eliminate efficacy, but does reduce it. And finally, the Novavax vaccine also directly evaluated South Africa. It's a protein vaccine with an adjuvant, a much smaller study of about 4,000 people in each arm. And in this situation, 6% were HIV infected, and almost all people infected with the B1.351 study. And you might remember the original study of Novavax vaccine showed a vaccine efficacy of 95%. And what we see in South Africa is vaccine efficacy is reduced. From mild to moderate COVID, the vaccine efficacy has gone from 95%, which was predominantly UK or Wuhan strain, to 50%. Just looking at HIV negative alone, it's 60%. Finally, the role of antibodies. This is just one slide of bamlanivimab, an antibody looked at as prevention, and it prevented COVID-19 morbidity and mortality in a nursing home setting. This is just presented at CROI earlier this year, BLAZE-2, which was a phase 3 randomized double-blind placebo-controlled study that enrolled residents and staff at a nursing home. 1,100 participants, all recently exposed to COVID-19, an elderly population, and very encouraging results of bamlanivimab reducing the incidence and severity of COVID-19 by 80%. So something to use if we're caught out without having vaccination having been done in the event of an outbreak. And hopefully these will become cheaper and more readily available. So in summary, we have 9 licensed vaccines, with the majority having high efficacy against severe disease and hospitalisation, but difficult to compare across phase 3 trials. No vaccine can induce sterilising immunity, but we are seeing reduction of transmission by 50% with both Pfizer and AstraZeneca, which is encouraging. We still don't know the duration of immunity, and little evidence so far of waning immunity. The role of annual boosters, whether original or variant of concern, still to be determined. Many studies ongoing with that in mind. And finally, no matter how good the science is or how good each of our countries are doing with vaccine rollout, we have to eliminate vaccine nationalism. We have to make sure that vaccines are available to everyone, and no one is safe until everyone is safe. And I shall end there and thank everyone in the audience, and of course all the healthcare workers that have done such an amazing job over the last 14 months in dealing with this pandemic. Thanks very much.